Good morning, guys. We should all aspire to offer best practice. Firstly, you need to understand what best practice is, mentioning no names. Secondly, you need to have the tools to be able to deliver best practice. And thirdly, you need to have agreement between yourself and the patient in what they are trying to achieve. Now, when it comes to testosterone replacement therapy, you need a confirmed diagnosis. And how do you confirm the diagnosis? You need pre-screening questionnaires, you need confirmatory blood tests, you need a face-to-face consultation with a prescribing clinician that understands the HPG axis, that understands the importance of hormonal balance, not just titrating your testosterone level to a certain number, because there are other hormones involved, estrogen, TRT, understanding that supraphysiological levels are not healthy, a lowering of the HDL, a raising of the LDL, raising of the hematocrit, raising of the blood pressure, negative side effects from excess estrogen, anxiety, water retention, blood pressure, breast tissue swelling. You need to appreciate that this is simply about normalization. This is not a lifestyle drug. So this is not to make you a stallion in the bedroom. This is not to make you super dad. That's up to you. All I can do as your prescribing clinician is optimize your male hormones and hopefully guide you on the right path. Now, the right path is appreciating the importance of all those things that we've discussed before: lifestyle, nutrition, exercise, and challenging yourself to earn that dopamine reward. So realistic expectations, they are fundamental to success. Because in reality, all this is about is normalizing your male androgen levels and reversing the negative side effects of having low testosterone, and appreciating that this is a journey. There is no destination. The destination's death. So let's delay that. Let's appreciate the moment, because this moment's very important. So, what are we talking about? Best practice. Establishing a diagnosis. Deciding if testosterone replacement therapy is in the best interests of the patient sat in front of you. So what tools are on offer? Well, within the NHS, the UK licensed drug for TRT is Libido. You also have the options of the gel, and hopefully either Sustanon or Enanthate. Now, according to the manufacturer, these medications should have a wide injection interval. Now, according to pharmacokinetics, they should not have a wide injection interval. Now, there's enough data out there to demonstrate peaks and troughs with wide injection intervals. There's enough data out there to suggest that microdosing, so using small amounts frequently, is a more effective way of achieving stable levels. I will take that one step further and say daily injections is the most effective way of achieving not only hormonal balance, but also mimicking your natural physiology. Hormones diurnal variation. It's a day-to-day thing. So measuring levels in a trough gives you data, but we are trying to avoid peaks and troughs. And what is the most effective way of doing that? Daily injections. You will always have a slight peak by the nature of injecting. However, to minimize that and to mimic, in theory, diurnal variation, daily injections of a short-acting ester such as cypionate or enanthate is the most effective way of doing that. Now, why do we do that? Why do we want to mimic physiology? Well, that really shouldn't be a question. We want to mimic physiology, not only for long-term physical and psychological health, but to also minimize potential side effects from hormonal fluctuations. By the nature of administering a drug, and in this case a hormone, there will be a physiological response. So there'll be a physiological response to the peak, and there'll be a physiological response to the fluctuation and ultimately the trough. We want to avoid that. So the most effective way of doing that is a small dose of testosterone daily. Intramuscular or subcutaneous? The answer to that question is the most effective way is subcutaneous, because, again, minimizing peaks and troughs. The testosterone ester needs to go into the vascular system to go to the liver to have the carbon atoms cleaved so that you can use the testosterone. To minimize a peak, you can delay that by administering the testosterone subcutaneously into the adipose tissue. So it gets dissolved into the capillaries and lymphatic system and eventually ends up in the venous system and then goes to the liver. That delay might seem arbitrary because obviously it still needs to go to the liver to be cleaved. However, we know that there is a decrease in aromatization administering testosterone via the subcutaneous route compared to the intramuscular route. Why is that important? Well, we have a propensity to increased aromatization, and that's conversion of testosterone to estrogen. And we want to avoid that. We want to avoid the negative effects of excess aromatization. We need estrogen, 100%. It's integral to your health. Cardiovascular health, bone strength, mood, to name a few, and also spermatogenesis. Have I discussed this before? Intratesticular testosterone gets converted to estradiol, which helps facilitate spermatogenesis within the testicles. But if I haven't, I've just done it. So, subcutaneous injections is the most effective method of achieving stability and minimizing the risk of aromatization of testosterone to estrogen. So where are we so far? Daily injections of testosterone cypionate, daily small injections to make sure that your blood parameters stay within normal physiological numbers. Because ultimately that's what we're trying to achieve. Microdosing. What else? HCG. We were informed by one of our patients yesterday that we're up to 20 pregnancies. So I couldn't be happier for my guy. HCG is integral to hormone replacement therapy, not testosterone replacement therapy. We should be looking at this as hormone replacement therapy. We know that testosterone suppresses the pituitary, and this can subsequently lead to infertility because luteinizing hormone is no longer sent down to the testicles. So, HCG mimics luteinizing hormone. So we should be maintaining function with HCG and topping up with testosterone. Remembering that the normal male produces between 5 and 7 milligrams a day. So let that sink in when you're administering 200 milligrams a week. Let that sink in when you're applying testosterone cream 20% twice a day. Is that an efficient, effective method of normalizing? And let's just make that point very clear. Normalizing male androgen levels for long-term physical and psychological health. So, if your dose is that high, either you are seeking supraphysiological levels or it's an ineffective method of replacing your testosterone. Makes sense, doesn't it? HCG alongside daily injections of testosterone cypionate to mimic your natural physiology. Let's touch on reference ranges for a second, because this is interesting. Reference ranges are decreasing. There is no doubt about it. So we have national guidelines called the BSSM guidelines. A testosterone level of less than 12 warrants a trial of testosterone replacement therapy, as long as there are obviously negative symptoms. So, abnormal. What is abnormal now? Since reference ranges have lowered, abnormal is no longer considered less than 12. It's considered like less than 7 in some places, less than 9 in some places. Now, what does that reflect? That reflects a sick society. I mean, what other explanation can it be? It's not evolution. Since we know that testosterone levels drop within advanced age, so aging is a process by which we become less fertile, less active, we become more susceptible to chronic disease, our muscle mass decreases, our bone strength decreases, because funnily enough, we're not supposed to be here forever. We're not supposed to be 70 and popping out kids. But good old Mick Jagger, oh, what a star. You old dog, you. So we are supposed to hopefully retain the capability to procreate. That's an evolutionary thing, isn't it? That's interesting, because obviously females, the typical age of menopause, 49 to 51, eggs are no longer produced because there's no biological incentive or advantage from females being able to procreate after that age, because they can't obviously raise the young unless they recruited sort of younger women. Which, why would your DNA want that to happen? It might make sense from a survival of the species perspective. It doesn't make sense from a selfish gene perspective. So community has arisen because of the selfish gene. Certainly it's a theory. There's obviously far more philosophical arguments and spiritual arguments that we won't get into. But it's interesting, just purely from a biological perspective, the selfish gene versus community. We are in communities to further our DNA, not everybody else's. But let's not go there. That's a long conversation. So reference ranges are decreasing. So what's considered abnormal now was not abnormal a few years ago. Scary stuff. Whether it's endocrine disruptors, whether it's cattle that are pumped full of estrogen to make sure they continue milking, and that urine seeps into the waterways, the ever increasing levels of obesity, creating too much estrogen, which then has an artificially elevated effect on the hypothalamus and pituitary, further suppressing LH and FSH release down to the testicles. There's lots of hypotheses. They're all very difficult to prove, but logic and reason would make you believe that these are very valid arguments. But they will always be hypotheses rather than solid facts, which is a shame, because obviously these things can then be doubted. And logical, methodical thought processes are dismissed by people who place an overemphasis on evidence, which sounds like a bit of a paradox, because we should obviously use evidence in making decisions about care and facts. But hopefully you can see the rationale in what I'm trying to tell you. So reference ranges are decreasing. We've got not only other studies, we've got lab reports from different times, and you can see it. There are decreases. There's also inconsistency from region to region. And again, what does that reflect? What can that possibly reflect? Could it be an issue with the study? Possibly. But it's more likely to reflect the fact that there are different levels of health in different areas. You know, we already know that from a socioeconomic perspective. There's an increase in illness with different socioeconomic classes. So that obviously makes sense. What's also interesting is the reference ranges change nationally. So we've got patients from all over the world. I asked my Norwegian guys to send their reference ranges, and some of their reference ranges go up to 35, 37. Is that because they're Vikings? Badass Vikings? It could well be, couldn't it? You know, there will be some genetic variation. So, guys in Norway, Denmark, Sweden, they may well have naturally higher testosterone levels because of their heritage. The Vikings. I'm not going to say anymore. So, yeah, you know, there is a genetic variation as well. So it becomes very complicated when you're trying to ascertain what is normal. Now, that question is really answered, obviously, by negative symptoms associated with low testosterone. And conversely, negative symptoms from having supraphysiological levels. Now, there's a cohort of people who believe that it's all about feeling great. So the qualitative symptoms outweigh the quantitative markers. Now, there's a short-sightedness to that statement because, as already discussed, supraphysiological levels cause physiological problems. Low LDL. High HDL. Low LDL. Stop. Rewind. Low HDL. High LDL. Raised hematocrit. And raised blood pressure. And psychological disturbances. Now, interesting. This has only been demonstrated in rats. So, you know, but it does make sense. So high testosterone levels are associated with a decrease in dopamine. Now that may in part explain why guys are more that they're more risk. They're more risk. I'm not trying to say averse is the wrong thing. I'm trying to say. I'm not trying to say averse. They're more likely to engage in risky behaviours and dangerous behaviours. Now, why is that? So it's a hypothesis, but it makes sense. High testosterone, low dopamine behaviours then are trying to achieve that dopaminergic reward. Makes sense, doesn't it? We do stupid things in order to achieve a dopamine reward in comparison to females. And your behaviour when you were younger, when your testosterone levels were at its highest, is very different to your behaviour in your 40s and 50s. Now, is that simply because of testosterone? Of course not. The weight of the world has crushed your spirit. It comes down to a multitude of factors. The weight of the world is a factor. Responsibility is a factor as well. Understanding the consequences of your potentially irresponsible behaviour is a big factor, hopefully. We're idiots when we're young, but the reality is we have no responsibility. And what are we supposed to be doing? If you go back to hunter-gatherer days, you're supposed to be going out to hunt, protect your community, gather food, have a bit of nookie. So what do we have to do in this modern civilized concrete jungle? Yeah, the machine is so crazy. It's so far removed from nature that we have the ability to buy a dopamine reward. We're led down a path that confuses us, but the machine is strong. So yeah, we're so far removed from nature that it's damaging our physical and psychological well-being. So we always talk about the need to get back to nature. And I cannot overemphasize that importance in mental well-being. It's actually well recognised that nature, I think it's Scotland doctors can prescribe nature. Peace. But wow, it's true. Wow, how amazing is that? We can prescribe nature. We should also be prescribing sleep. Sleep is fundamental as well. Rest, recover, and grow so that you can engage in the day. It all makes sense, doesn't it? So, best practice. Testosterone cypionate and HCG via the subcutaneous route. Daily injections to mimic your natural physiology. Work with nature, guys, not against it.